Thank you, Nick. And thank you for that talk. That was great. I can really echo that. A lot of the people I work with find changing their breathing really, really powerful. It's that access point, isn't it, to the autonomic nervous system and to soothe it. So thank you very much. Our feedback from the last masterclass was that you would be really interested to have a talk about psychology. And whilst in part I was thrilled at that, because I really do feel passionately that people with chronic health issues of any kind can really benefit from psychological support. I chose this slide not just because I think the doctor looks bizarrely like Nick, but also because I wanted to call that kind of white elephant from the outset. It can be very difficult to talk about psychological factors with patients, and it can really feel sometimes like I'm walking a tightrope, because a lot of patients have been told in the past that their experiences are all in their head, so they can be quite resistant. We know that no one in this room, but a lot of medics also kind of hold this belief that that somehow POTS is just a different kind of yuppie manifestation of anxiety. But at the same time, yes, I really do feel passionately about the fact that psychological factors are important and can be really helpful. So riding on the coattails of some more illustrious colleagues, we looked at kind of what do we actually know so far in terms of data about psychological factors in POTS. And obviously we know that POTS is not a conversion disorder. It gets quite confusing looking at studies about anxiety in particular in POTS, because obviously some of the symptoms of POTS are equivalent to those that picked up in sort of anxiety measures. But actually, what seems pretty clear is that levels of mood and anxiety are not dissimilar to other conditions with similar impacts on quality of life, such as COPD. There's also some evidence, patients really get upset about their brain fog, and often that's what they're complaining about the most. And there's some evidence that cognitive function is compromised in an equivalent fashion to ADHD. And we also know, quite worryingly, that patients do tend to have increased suicidal ideation, and that's obviously of a great concern and something for us to think about. Pretty much the rest of this talk is the world according to me and my experience. So, but I just at this point want to say that obviously we've talked about this, patients really vary a lot. And so, while most do better with psychological intervention, everybody's coming with their own picture when it comes to this. And we know that often patients have had a bad experience in the past, and that can really affect their take-up of support. I want to flag this concept, really, that having any chronic health issue is very often a trauma. And by that I mean that it's something that's coming out of the blue that we just can't process, just can't accept, and doesn't have a natural endpoint to it. We don't get a moment where we think, phew, that's all done, and have a chance to process it. And that sometimes having this trauma can actually exacerbate previous traumas in people's lives. And I just put this picture to illustrate that this rather gorgeous image is of a heart sink, and we don't ever want a patient to be thought of in that way. You know what? All of us in the room, as well as our patients, are wanting to establish basic ways of finding happiness in this world. And that, as a team, is our task. So I'm going to race through the why psychology, the when, and focus as much as I can in a very short period of time on the how. And really want to just emphasize some themes that I've seen a lot with people that I've worked with. So a lot of patients are really quite separated from their body. They're quite dissociated from their body. And whether that is as a result of the condition being quite scary, so they're kind of pulled back and not in tune with their body, or whether there are previous experiences that contributed to that, what that often means is that patients have got in the habit of just pushing through the pain they're experiencing. And I think that's a factor sometimes in missing out on tuning into kind of cues that they're overtired, or missing out on kind of prodromal cues that they might otherwise tune into. And often what we're working on actually are coping factors that are very natural that patients are employing to try and deal with their health, which are actually counterproductive. So, For example, trying to rest in the beginning or avoid situations. I could talk all day about mind-body interaction. I probably have, and I don't have a lot of time to talk about this, but I guess I want to, show that when I talk to patients, I often really do pitch this idea that the two are very integrated. That actually feeling supported and having some hope is really powerful and genuinely can impact our physiology. If anyone wants to talk about the mice, get me at lunchtime. So importantly, as I've said, I think a lot of patients really benefit from having some support, but there are also some flags for when it's particularly important. And I particularly want to emphasize this kind of increased rate in suicidal ideation with patients. Don't ever be afraid to ask. I think, unless we've been told this, we can feel sometimes we almost don't want to suggest or bring up that our patients might be thinking about harming themselves. Nobody's ever followed through with an act just because somebody else has suggested it to them. And people are often very candid about how they're studying and how they're feeling. So do ask and do get the crisis team involved if you need to. I put together a table for the autonomic neuroscience paper, which kind of really runs through what I think are a lot of the really important psychological skills that patients can benefit from and the techniques that can help and kind of why that might be important. And that is on open access if you want to get hold of it, and something similar will be in the practical guide when it comes out. So I won't run through too much of that now, but perhaps just move on to looking at some of the techniques we use and to talk about some cases as well. So CBT, cognitive behavioural therapy, a lot of people know about this. The general premises that the way we feel is impacted. It's not just about the situation, it's about the thoughts we have about that situation, our feelings, the way we behave. And that enables us to help people manage those thoughts and behaviours to improve the way that they feel. So the general premise is about being a good friend to ourselves and about kind of aiming for the gaps and not the trees if we want things to end well. So when practicing CBT, we're looking and helping patients identify some unhelpful patterns. For example, catastrophizing, getting caught in thoughts about things getting worse and worse in the future, and how would they cope then? And so the evidence for this, CBT is recommended by NICE for a range of various health conditions. Indeed, it can be very helpful in helping patients kind of gather a bit of a toolkit for managing them. But actually, my sense is that, and I've got some quotes here from a couple of people I've worked with, that actually CBT can work really well when patients are very skewed in their thinking. So when they've got very caught up in the negative things in their life and they're not able to see the positives. But it can be less beneficial if things actually are really quite awful. And we'll talk about some other techniques that can help with that as well. And one of my favourite is an approach called acceptance and commitment therapy. A really super book here by Russ Harris that actually I would encourage all of you to perhaps put on your Christmas shopping lists. This is really about the idea that life throws tough stuff at us and that trying to avoid difficulty is rarely helpful. And sometimes we need to just put all that difficult stuff on one side and focus on living according to our values and working out what's important to us and how, even in a more limited way, we can still fulfill those when we're unwell. And when that comes to illness, then we're really looking at how do we kind of accept some of those limitations. And by that, we don't mean giving up on getting all the help from all the practitioners we can, but to just not fight against all the time the disappointment and to move instead to focus on kind of growing the parts of us that we kind of can have some values around. And part and parcel with that approach is using a lot of sort of mindfulness and meditation skills. which are all about really coming back to being in the moment. So really helpful for all of those racing ahead type thoughts about envisaging a really disastrous future. So it could be really useful from pulling back from getting caught up in all those thoughts and emotions that could really weigh us down, and instead practice that ACT approach of really throwing yourself instead into living in a way that feels really important to us. And there's some really good evidence about meditation really impacting on some kind of core physiological measures that are really relevant to POTS. And, it can also be really useful for medics as well. I can hear a few titters as you look at the cartoon, but, we really find that the doctors who meditate regularly are more empathic, find their work more rewarding, get better results, and their own health is better as well. And a lot of this information can feel very overwhelming. If you've heard me speak before, you might have seen, I really like using this sort of 5 elements technique to help patients pull together all of this different information in a way that feels manageable, so that if they're having a bad day, they can look and think about, is it that I haven't been having enough water? Have I been forgetting to do the fun stuff in life? Have I not been exercising? Have I not taken the time to really get calm? A lot of the work that I'm doing with patients is to really help them find their own way of pulling in the parasympathetic nervous system to really look after themselves in that way. And of course, make sure they're taking their medication, and if they aren't, why not? So I'm going to race through those just on the basis of time, and just talk about a few different cases. So this first example is of someone who had no sort of pre-morbid psychological difficulties. So a young lady who was flying all around the globe, a very kind of jet-setting, exciting lifestyle, and then suddenly had a viral condition, and then the range of symptoms that we all know about. And she was particularly struggling to adjust to this huge change in her lifestyle, and to find that friends and family were not always very supportive. So a kind of typical picture, really, of the very genuine struggles that most of our patients are probably talking about. And in working with her, helping her kind of really become empowered to manage her own condition was really important, but also really thinking about how could she begin to make decisions in a less of I'm going to New York or I'm not going to New York and I'm going to fly on the overnighter and do an all-nighter way, but to really adjust to living well and still meet her values. And for her, again, this picture of teaching her own way to get calm, of how to look after herself was really important, as well as just really getting assertive in her interactions with people. Patients need to be able to say, I'd love to do the dishes, but I absolutely can't, or if I do, I won't be doing anything else for a week, so muck in. It sounds so basic, but actually having the skills to do that can really make the difference between life being manageable or not. A brief mention of a really lovely young lady as an example of how when patients are misdiagnosed, actually, and they've been stuck from a very early age in a psychiatric pathway, that things can be very difficult. So we can't time travel. This young lady is in her 20s now, but she was a long-term inpatient from the age of 11 with what now sound to be a very similar sort of profile of experiences that young people with POTS experience. And that in itself, of course, has attachment consequences from being in hospital for such a long time. And she was told that she had a dissociative condition, which really sounds like, well, it could be a sort of brain fog type presentation. And for someone like that, obviously, in many ways, to finally get a diagnosis is really helpful, but there's a lot of loss to navigate with that as well. And when we're told that we have a sort of dissociative personality disorder, there's a no-hope picture in that. So there's a lot of work to do, actually, in starting to feel empowered to step up and to feel that you can manage your condition. So really positive, but a challenge. And I've just kind of flagged abuse here as well, because, again, it's another white elephant, I think, in the room. I've heard doctors say, I've noticed a lot of these young people have, a lot of abuse in their background. And unfortunately, the reality is a lot of young women do. About a quarter of young women will experience sexual or aggressive trauma at some point. So yes, I think that having the trauma of ill health can also exacerbate previous trauma, but I don't see there being a causal pathway any more than there is in any other health condition. And then finally, one more case. How am I doing for time? Oh, okay. I think I'm going to run past this young lady, therefore, on the basis of a lack of time. But it's an interesting situation about somebody who experienced PTSD after an ablation and developed POTS, and how important it was for her to find a way of managing that. So a different scenario, really, of somebody who needed work on PTSD in order to actually manage her POTS symptoms, in order to optimize her well-being. So patients really report that having someone that understands the condition is important, that invalidation is very traumatizing for them, and also that having hope is a really important part of starting to navigate a health condition. So let's move on. Okay, so what does this actually mean for you that are working with patients? Having a take-homeable diagnosis and a plan can be hugely empowering for patients who have kind of had to feel like they're fighting against being told there's nothing wrong with them. Having ongoing support so that they're not feeling isolated, but also feeling empowered to manage their condition is really important. In terms of accessing support from psychology, you can play such an important role in normalising that as part of any chronic health condition. And to talk perhaps about the way that all chronic conditions are about managing them well, is about reducing stresses of all sorts, including life stress. I think in that vein, it's useful to talk about, the body as not being a machine, but being an ecosystem, and our moods and our emotions being a bit like the weather that really affects how the rest of the system functions. And sleep actually is often a really good way of starting to talk about psychological factors, because most patients struggle with sleep and can recognise that stress can be a factor in that. Again, another white elephant is patients really reacting against any sense that if psychology is a factor, is it their fault that they're unwell? And I think that line that we're responsible to our illness, but not for our illness, is really important. So you offer a really important intervention when you offer hope and when you validate patients' experience. And really, these final thoughts are about kind of being a good soul, of being authentic, being compassionate with your patients. I love this list of 5 agreements as a take home, because it's a great way to live life generally, as well as to work with patients. In this time of fake news, we need to be skeptical, but we need to learn to listen. And let's remember that our patients are really looking for hope, to be heard and to be held. And if we're doing that, we're doing something very positive. Thank you.